morning and welcome to our weekly CMR conference series hosted here at VCU. I'm pleased to be given the conference this morning on MRI contrast agents, which whether you work in the MRI space or not, I think this is something that will come up in the routine clinical care of patients in the cardiovascular space, just because of how routine it's becoming to obtain CMRs or just any kind of MRI type exam during your clinical care. And so just a reminder of everyone that these sessions are CME and MOC accredited. Don't forget to text the code on the screen to the number provided. For any MRI technologists in the audience, this session is ASRT accredited, so you can claim 1 credit hour. Unless things have changed, you do have to be logged in under your own user ID on Zoom. So if a few of you are watching it together, make sure that each of you log in individually. They make us do something to track attendance, and that's the only way we've found out how. So anyway, so you can claim ASRT credit as well. So with that, I'll go ahead and get started. Let me share my screen. Okay, so this is the overall outline of the talk. First, I'm going to talk a little bit about just the principles of contrast agents, their physics, and why we can leverage that to enhance our clinical exams, the pharmacokinetics of them. Talk mostly about the gadolinium-based agents, which is what we routinely use in clinical practice. Talk briefly about some of the alternative substances that are used in contrast agents, more in the investigative field, but some have pushed for using them in the clinical space more readily. And then talk on some adverse events, which is a common source of questions from both providers referring for these studies and also the patients themselves. So to start with the basic principles, I'm sure everybody will readily be able to recite the periodic table of elements from their undergraduate and graduate level training. And so you have paramagnetic ion complexes, and here they are: gadolinium, manganese, dysprosium. And there are also super paramagnetic magnetite particles, including iron oxide. And so what is particularly beneficial to us about the paramagnetic ion complexes that they have a number of unpaired electrons, including gadolinium, which has 7 unpaired electrons in its electron shells. Again, I'm sure I'm just reciting what you already have readily at your fingertips and your base knowledge from training in undergrad. But those unpaired electrons have some interaction with water molecules, and in doing so, they exert certain effects on it, so that, as Dr. Hundley likes to say, we can just see water better. And I'll show you what that means in a moment. So the overall effects of gadolinium is that it increases the signal intensity of T1 weighted images, decreases the signal intensity of T2 weighted images. At the lower gadolinium concentrations that we tend to use in the MRI space, it has a T1 shortening effect. If you were able to use doses high enough, you would also get a T2 shortening effect, but you can't get to doses that high with the gadolinium-based contrast due to toxicity concerns. And then the transition metal ions, such as iron oxide, have very strong effects on T2 relaxation, which again can be leveraged in the MR imaging, and we'll sort of talk about that later. If you just gave straight gadolinium, you can't do that. It'll immediately be taken up by the reticuloendothelial system and accumulate, and you'll have all kinds of toxicity related to heavy metal deposition. But so what they do instead is chelate it, and so in providing it with a chelation structure, you reduce the toxicity of these metal ions. And so there are different combinations of properties of the different contrast agents with gadolinium based on their chelation structure. So it can be ionic or non-ionic, hydrophilic or lipophilic. And then based on the chelation structure, you have a different biodistribution, right? So either the contrast agents will tend to accumulate in the extracellular space, or they'll tend to remain in the blood pool. And so the extracellular fluid agents, they will circulate freely and then distribute into the extracellular space with different rates of distribution. And when they're excreted, they have mostly a renal elimination, which, as we'll get into, has some implications for those with renal dysfunction or end-stage renal disease. The blood pool contrast agents, on the other hand, they tend to remain in the intravascular space longer, are excreted more slowly. There's a number of ways you can make that happen, either by allowing for binding to albumin to try to prevent leakage of the contrast agents into the intravascular space. You can simply increase the size of the contrast agent, which slows down how much it leaks through endothelial pores, or using nanoparticles to change the route of elimination. And so, you can imagine already based on the reason for exam, you might want to choose one over the other. So for instance, if you want to just look at the vasculature, if you're doing angiography, then a blood pool contrast agent would actually work quite well and maybe be advantageous. If, on the other hand, you are someone who is interested in looking at tissue characterization and you want it to escape the intravascular space and seep into places like the myocardial scaffolding, the extracellular space within the myocardial architecture, then you don't want a blood pool agent. You want an extracellular fluid agent, which is typically what we are using in the CMR lab. This is a list of the FDA approved contrast agents. I've highlighted a couple of them, which is Prohance, which is just at our institution. This is what we tend to use for our cardiac exams. I know Dotarim is another one that we've been asked to use on some multi-center studies. It's pretty common. And then Multihance is one that every now and then we end up using. It's more, I think, if the study's combined with an abdominal study, or if they're specifically looking at things like angiography, and you want to see the vascular space very clearly. Gatavist right here is the only one. I tried to check right before giving this conference again, just to make sure this is still true. But as far as I'm aware, Gatavist is the only one that's actually FDA approved specifically for cardiac scans. Before that, everybody had to put a disclaimer in the talk that they're going to use, or they're going to discuss the use of the off-label use of gadolinium-based contrast agents for cardiac exams. But as of a couple of years ago, Gatavist was approved specifically for cardiac exams. And so here we have on table 2 is extracellular fluid space agents. And so here Prohance, again, is the one that we use. Multihance is listed here, but it's also listed down here, the blood pool contrast agent. So it kind of rides that border between staying in the intravascular space and seeping into the extracellular spaces as well. And then here, as I mentioned, Gatavist. I usually try not to use trade names exclusively, but these chemical compounds are so hard to pronounce that I'm just going to use that today. So Gatavist is the one that, as of 2019, was approved for cardiac MRI. So now that we've gone through that, and actually, let me go back and just point out one thing really quick, which is that you'll notice that all the different chelation structures are designated either macrocyclic or linear. So things like Prohance, Gatavist, Dotarim, these are all macrocyclic chelation structures. You can see Prohance right here is sort of a series of cyclical looking structures, as opposed to other things like Multihance, which it doesn't look like exactly a straight line, but this is considered a linear chelation structure. So macrocyclic versus linear, blood pool versus extracellular space, these things are going to become important later. So that being said, how do we use these gadolinium-based contrast agents in the CMR environment? There's quite a number of ways. So just to start with is perfusion imaging. So basically you can look to see as you inject the contrast agent through a peripheral IV, you can watch the first pass perfusion to see that as the contrast enters the venous and then the pulmonary arterial and then the left ventricular cardiac chambers and then the arterial phase, and then it starts to perfuse various organs, the heart itself, or something, you know, nearby the heart that you want to know, does it have avid perfusion? You could take advantage of these perfusion sequences. And so, you know, just looking at common cardiac masses, whether or not they take up contrast, it can be a very good discriminator sometimes of whether or not it's malignant versus benign, and so forth. And so you've got a few different ways to try to tease that out, but whether or not it takes up. So again, here is as the blood is injected, or as the contrast is injected through a peripheral IV, you see the right ventricle light up first, and then in the lungs you see the pulmonary arteries, and then the left ventricle cavity is starting to light up. And then as it enters the arterial phase, you see the myocardium start to slowly brighten up. And so too is, for instance, the liver and the spleen and the kidneys and every other organ. And so you can see how, of course, the myocardium is very avidly taking up this contrast because it has very avid perfusion. And so here's an example of a mass, a mass here within the interatrial septum, kind of extending along the right atrial wall. And the question is, if you know, maybe it's obvious already, but is this something that's malignant or has avid blood supply that we need to be concerned about? And so here we are in the first pass perfusion, and you can see that after injection of the contrast, it does tend to brighten up serially with contrast. So the signal intensity starts to slowly rise. And so, yes, this ended up being an angiosarcoma. Okay, I answered the poll myself. So here's another case where you can see that there's a abnormal thickening within the right ventricle, and then in the right atrium, there is a large mass-like structure within the right atrial cavity. And so the question is, does this have blood supply? And so here we are in blood on the first pass perfusion, and you see it just remains sort of jet black. It never really brightens up, even when you wait quite a while after contrast injection. Here it is in the other view, never really brightens up. So this is a thrombus. You know, this is a thrombus isn't necessarily a benign thing to see, but then again, it just doesn't have a blood supply. And so that's one of the good ways to discriminate between masses that you might find. We do use this first pass perfusion in our stress studies too. It forms the basis of our vasodilator stress studies, and sometimes our exercise studies, though you're sort of limited in time after exercise. And so if you exercise someone, you got to choose, what are you going to focus on in the next 60 seconds? And usually we focus on wall motion. If we can get perfusion, it's a little bit kind of like the cherry on top, but usually we focus on wall motion and don't worry about the perfusion as much. The vasodilator, on the other hand, is all based on looking for perfusion mismatches between stress phases and rest phases. So here's what this looks like. So here's a stress test where these are just standard cinematic images where we see that in the 4-chamber view, 2-chamber view, 3-chamber view, all of these are 60 degrees off from each other, and wall motion is very well preserved. There's no segmental systolic dysfunction. And here we are on the top is our stress, where we've given the vasodilator agent. Either adenosine's been running for 3 minutes, or we gave a shot of regadenoson and we've let it reach steady state. The patient's become a little bit more tachycardic. We give the perfusion, or we give the contrast agent. We look for any perfusion defects, which I don't really see any here. And in this case, we didn't necessarily need it, although we've had some odd cases where they've had a paradoxical perfusion defect. But for what it's worth, the rest phase shows also that there's no perfusion defect. So this is a normal study, a normal stress study. Take this case instead, where you see in the 4-chamber view, this anterolateral wall looks a little bit hypokinetic. The inferior wall in the 2-chamber view looks hypokinetic compared to you see how it's moving, but it's not really independently thickening, not nearly as well as, say, the anterior wall. And then here again, the inferolateral wall, you might even argue portions of the anteroseptum right here are hypokinetic. So already there's some signs something's wrong. Well, let's look at the stress test. And sure enough, this is a base, mid, apex. You see in the basal segment, the lateral wall extending all the way down the inferior wall. See how it sort of stains in the myocardium, and there's portions of it that really don't brighten up appropriately. And here it is in the apical segment, really pronounced. And so there's a few things that I'm just gonna, let me see if I can pause all these so it doesn't. So there's a few things that make these pretty typical for a real perfusion defect as opposed to sort of a fake out. We have some artifacts like dark rim artifacts that can sort of trip us up sometimes. This is, this defect lasts more than 10 beats, 10 cardiac cycles. It affects more than 1/3 of the thickness of the myocardium. If you look the darkest portions along the endocardial surface, and as you move out to the epicardial surface, there's sort of a gradient. There's a point where it starts to slowly brighten up before it reaches the epicardial surface. And it's also in a coronary territory, right? This would fit pretty well with the circumflex territory, or maybe a dominant right. And so it really, everything lines up for this being a real perfusion defect, and these are sort of the things we look for. And sure enough, this patient turned out to have multivessel disease. And so I do just want to kind of show this again, because I feel like we say sometimes in the lab that it's helpful to recalibrate what's abnormal. Sometimes we see a lot of stress studies come through at our institution that forms a pretty sizable subset of the exams that we do. And so you're bound to see a lot of dark rim artifacts, and it's nice to see a true positive like this. I mean, there's no doubt about it to kind of recalibrate what you're looking for. So the other thing that we use is delayed enhancement, which sort of forms a workhorse of our tissue characterization. Not trying to put down parametric mapping or anything, but this still is sort of the go-to tissue characterization techniques that so much of the literature is based on, and is quite reliable in our study exams. So if you look on the left at the normal myocardium with an intact cell membrane, the gadolinium contrast agents really should not penetrate those, and so you should not get any increasing signal within the myocardium itself. Now in the extracellular space, you should, the scaffolding around the cardiomyocytes, but not in the myocardium itself. And then with an acute infarction or other mode of damage like myocarditis or what have you, there is disruption of the cell membrane, and so now the gadolinium contrast agents can penetrate into the cardiomyocytes. So you'll see that effect on our scans, and then ultimately, if it lays down scar, a collagen matrix, then that does have a high water content, and so you will see penetration of the gadolinium-based contrast agents into a scar. So again, the way we do this is we give the contrast agents. We typically wait 10 minutes, and then we do an inversion scout sequence to watch this effect here. So what we're looking for is an inversion recovery. We administer an inversion pulse, invert the spins, watch them recover. So the blood pool typically is the one that recovers its signal first. And then normal myocardium and focal scar will follow a contour that sort of resembles that of the blood pool. It can be hard sometimes when there's an endocardial lesion to distinguish between the blood pool and the lesion itself. You can take the absolute value of those, and so this is a magnitude reconstruction. And then again, so what we do is we take an inversion pulse, and then we take picture, and try to identify, where does the normal myocardium null, and then the time between the inversion pulse and that normal myocardium nulling becomes your inversion time. So every time we take an image with like gadolinium enhanced imaging, we set the inversion time given, and so then it'll administer an inversion pulse, and we wait a set amount of time, our inversion time or our TI, and then acquire the image so that we know that the normal myocardium should appear black since it's on this zero line, and focal scar and blood pool should appear some shade of bright white. There's also phase sensitive inversion recovery, or PSIR, where you can sort of make use of the fact that if things are below the baseline, they should not show up as bright, because that's what will happen over here. And if you screw up your inversion time, it's a bit more forgiving, and certain conditions like amyloid really is hard to get any kind of magnitude reconstruction. So here's our normal TI scout, where again things start bright above the baseline, and then the blood pool nulls, and then the myocardium nulls, and then everything starts to brighten up as it regains its signal. So I'm going to kind of skip through this a little bit. So this is what it looks like. Of course, we're sort of familiar with this. This, I think, yeah, so on the left is just a single shot. So every single slice was acquired in one heartbeat. And so you get all the data right at once. There should be no, problems with gating issues or motion issues. But the resolution isn't quite as high, as opposed to on the right. This is a segmented acquisition where, each slice, the data is acquired over multiple heartbeats and compiled into one composite image. And so the resolution is much higher on it. And so if we like to get these, but sometimes this is happening at the end of the exam, and patients are having trouble holding their breath by this point. We've worn them out, and especially those who have significant cardiac conditions and they're sick and they have trouble holding their breath. And so sometimes the single shots, might be the best that we get, or we have to go to the dreaded free breathers. Anyway, once you acquire these, this is a commonly referenced graphic showing the different enhancement patterns, and with ischemic cardiomyopathy showing mostly subendocardial or even transmural infarcts, and the other various entities showing different enhancement patterns. And so again, this is why late gadolinium enhanced imaging sort of remains the workhorse of our tissue characterization and cardiomyopathy identification in many cases. And you name it, pick a disease. If you have late gadolinium enhancement, in general, your prognosis is worse. So this is patients with spontaneous. This one's just patients with ICDs, and if they have what their percent scar is and whether or not they have shocks. This is dilated cardiomyopathy. Patients with more LGE tend to have worse events. This is hypertrophic cardiomyopathy. This is the paper that sort of gave us our 15% LGE threshold as a marker of who's at risk for having sudden cardiac death. Sarcoid, amyloid, again, you name it. More LGE typically means worse things for the patient. And then, just confirming our use of first pass perfusion imaging for stress tests was the SPINS study, which was a large multi-center retrospective or registry of sites that had been using stress CMR for, I think, at least 10 years or so. They had been doing this for 10 years to enter the study, and just sort of compiled over 2,000 cases, and established that those who have signs of reversible perfusion defects and or late gadolinium enhancement tend to be the ones that have worse outcomes down the line. They use the term ischemia. I think it's, maybe in a lot of cases we're not actually inducing ischemia, it's just a perfusion mismatch, but you can have a steal effect when you give a vasodilator and induce ischemia. And so a lot of the papers will just go ahead and call it ischemia. And then as Dr. Hunley referenced recently, the extent of late gadolinium enhancement forms the basis of much of our viability assessment. So again, he went through this, where if you look at the area affected by late gadolinium enhancement and the area not affected by, that has normal myocardial signal, and you take sort of the ratio of those areas segment by segment, you can sort of predict who, if you revascularize them, which segments might be likely to recover segmental systolic function. Now, I know that this has been thrown into question a little bit with the revived BCIS trial. We should certainly visit that trial and what its implications are for how we think about viability in the MRI lab. But much of the data using CMR, because there's other ways of looking at viability, seems pretty promising that, if you don't have scar, you're more likely to recover some function in that segment. If you revascularize it, if it's just complete transmural infarct, don't even bother. What's the point of revascularizing just a scar at that point? Okay, angiography. Here on the left, we can administer it, wait until it reaches the phase of interest, in this case, the aorta, and then acquire the angiography sequence. So we get very high resolution angiography. I won't go into this too much. I know Dr. Grizzard gives a talk on this and covers it quite well. As I mentioned, thrombus, I guess you could consider this exploration of a mass, but thrombus has some particular characteristics that make it helpful, which is that if you do one of those late inversion recovery sequences, like what we use for late gadolinium enhancement, thrombus takes a very, very long time to recover its signal. So you can do these, which are long inversion time sequences, where rather than a typical inversion time that we might be using for on the 3 Tesla scanner of like 300 milliseconds or so, you set it up to 600 milliseconds. And so what you see is that the blood pool, the myocardium has all regained signal after that inversion pulse, and everything shows up as a bright shade of gray or even white. And so this is a patient, we take it as multiple different slice offsets, post-contrast, long TI imaging. We don't see any dark spots here, as opposed to this case where you see within the LV cavity, there's a large area with very, very low signal intensity, despite this being at a long inversion time. And so this is characteristic of a thrombus. And so that's what's really nice about it, is it really jumps out at you when it's there. I will say that, sometimes if you have someone who's had a myocardial infarction and they've got microvascular obstruction, it can be a little bit hard to tell, is it thrombus versus a microvascular obstruction. The difference that we've used sometimes is that if you do more and more delayed imaging, so you wait, instead of just 10 minutes, you wait 20 minutes, 30 minutes, then really that microvascular obstruction region should start to fill in on these sequences, whereas thrombus should not. The cost of that, of course, is that you have to recognize it in real time and keep the patient on the scanner longer, and it sort of it might affect your throughput a little bit for the day, but you can get to the answer if everybody thinks of it at the time. And then recent paper looking from University of Minnesota, I think this is Chetan Shenoy's group, where they do these routinely, these long TI sequences, and so they looked at if you had a thrombus versus not, how did you do compared to, so if you had a thrombus, how did you do compared to a matched control group that did not have a thrombus? And intuitively, the patients who had LV thrombus had worse events down the road. Interestingly, they looked to see in patients who had an echocardiogram within a certain number of days, I don't remember the exact time frame, how likely was the echocardiogram to find the LV thrombus. The sensitivity of echo was only about in the 50%, and if you use echo contrast, it was still only in the 60%. So the sensitivity of CMR is much higher than echocardiography for finding these thrombi, especially if they're not sort of close to the apex, I presume. And then extracellular volume calculation. So this slide has been shown already in this conference, but late gadolinium enhanced imaging, as I showed you, is good for looking at focal scar. If you have one area of the region that's wildly abnormal with reactive fibrosis, as opposed to replacement fibrosis, and then as opposed to if you have something that's diffusely affecting it, like long-standing hypertension, diabetes, or exposure to anthracycline, what have you. then that's not a good technique to look for it, because you're going to end up nulling to the myocardium on your TI scout sequences, and you won't realize that you've just nulled to something that's actually abnormal. It's got interstitial fibrosis in it, and there's really no way to tell on those sequences. And so the alternative approach to that is to get pre-contrast T1 mapping, post-contrast T1 mapping, and then by using a formula that includes those values plus the hematocrit, you can come to this calculation of an extracellular volume percentage. And I think Dr. Hunley was given some values where, you know, if you're young in your 20s and you expect this ECV value to be about 20% or so, someone who's aging might expect it to rise steadily up to 25% range, and then higher than that tends to be associated with the pathology. And so this is another classic graphic that's used in a lot of presentations where you see, you know, various diseases that will raise your T1 values and also your extracellular volume percentage, with amyloid sort of being at the most extreme cases of both. And I used to sort of wonder if they sort of follow X equals Y, sort of linear association, what is the value of ECV? But I think I've come to understand it as a couple things, which is that ECV is like the INR of T1 values. So T1 values can vary based on scanner, field strength, vendor, those types of things. And so it's hard to read an article that tells you certain T1 values and then bring that home and use it on your own scanner, because it might not be the same calibration, whereas ECV should be the same across institutions. And also with conditions like amyloid, once you reach a certain threshold of deposition, the degree of amyloid deposition mirrors the ECV calculations much more closely. There's a nonlinear sort of association with the native T1 values, and so ECV becomes a superior surrogate of amyloid burden, essentially. Kind of skip over this. So I'll touch briefly, like I said, on a couple of alternative contrast agents. So manganese is one that's been described as it's a calcium analog is how it acts. And so it crosses the myocardial L-type voltage-gated calcium channels and the sodium calcium exchangers. And what ends up happening is you get a T1 relaxation that's similar to gadolinium. But what that means also is that it's directly crossing into intact, healthy cardiomyocytes. So as opposed to gadolinium contrast, where it will not penetrate the cardiomyocytes and it will only go into other places where there is higher water content, like focal scar, this actually goes into the cardiomyocytes themselves. And so you could use it for things like viability, except you're looking at the intact myocardium rather than the scarred out myocardium. And so the danger of this is that if you flood the calcium channels and exchangers with manganese instead of calcium, which is what it needs to function, you can end up with myocardial depression because it'll sort of compete with calcium ions themselves. And so the way they've tried to overcome these toxicities is to chelate it, or co-administer it with calcium at the same time. And so there's a couple of agents that have been described from this review article where this agent, which was previously being used clinically for hepatobiliary neoplasms, and it's now been withdrawn from the market because gadolinium-based agents really sort of took over the market and reduced demand for this. There was another one where, was in a various stage of development, which had an alternative method to chelation, and the authors of this review article thought it showed a lot of promise. I haven't really seen it develop further. But what's interesting about it is that here you are at baseline. This is a manganese enhanced MRI T1 mapping. So baseline, and then once you give the manganese contrast agent, then you see the myocardium starts to brighten up, or depress on this color scale, and it really stays that way for a long time. out to 40 minutes, which you can imagine might have some, you could use that differently than how we use it. The gadolinium-based contrast imaging agents wash out relatively quickly. So sometimes we find ourselves in the situation where we're running out of contrast, but this is staying out to 40 minutes, which is kind of nice. And then so here you are with native T1 mapping in a patient with acute with a myocardial infarction. And then manganese enhanced. So you see that the normal myocardium is affected by the manganese contrast agent. And then here with standard gadolinium contrast enhanced agent, you see that the area that enhances is a scar instead. So it's sort of showing you two different sides of the infarct, two different sides of the viability. So it's kind of interesting. There are also iron-based agents. So we can use so ferromoxidase was one that was used for imaging in the liver and reticuloendothelial system. It's a slow IV infusion as opposed to the pushes that we give with gadolinium contrast. There were a not so insignificant incidents of allergic and anaphylactic reactions in this. And again, this one is sort of the market's been taken over by gadolinium-based contrast imaging for hepatocyte imaging. Baramoxetol is one that's been described as a member of the ultra small super paramagnetic iron oxide or USPIO particles. And so what's nice about it is that it's coated in a dextran coat, which diminishes its immunogenicity, and it's got a slow uptake by macrophages. So the other thing is that it's been studied in patients with severe renal dysfunction, and it's actually approved for iron deficiency anemia. So when you start to get into patients with renal dysfunction, this isn't necessarily a concern for them because after all, it's approved in that population. And so it could be used as an intravascular agent. So here is an example of a angiography being done with paramoxetol. And you can see a nice little dissection flap here, and up to 60 minutes, everything, of course, the arterial and venous phase are enhanced, but, you still got this nice enhancement from it. Or in the myocardium, it can show the inflammatory cell evolution following an MI, or there's been some really interesting work where they've looked at things like Takatsubo, Dana Dawson's group. She came and spoke to us a couple of years back about her work, but it's taken up by the macrophages. And so what you end up with is areas that have active inflammation will be enhanced by these techniques after giving paramoxetol. Okay, so that being said, let me move on to adverse events, because this is a very important part of contrast agents and what we'll get asked on a lot. So just to start with, and I'm only going to speak mostly about the gadolinium-based contrast agents because that's what we actually use clinically. The physiologic reactions are fairly common, and I'm sure the MRI technologists are not impressed with it. They know how they see this all the time. They are used to this, where patients might have various side effects, including this nausea symptom, where as the contrast goes in, patients feel a sudden rush of nausea and they think they're going to throw up and might start to gag a little bit, and they might even throw up a little bit, and then it's very, very quickly diminishes and doesn't last any longer than moments. Extravasation of the contrast agent is a rare event in general. Its laboratories suggest that the gadolinium-based contrast agents might be less toxic to the skin and soft tissues than equal volumes of iodinated contrast media. And usually with the small amounts that we're using, there's a pretty low likelihood of compartment syndrome. But if it does happen, the standard management of this is to ask the patient about any pain or paresthesias associated with it, examine the active and passive range of motion and the perfusion of the fingers. You're just trying to rule out compartment syndrome. You can have the patients elevate the arm above the level of the heart to try to help their body reabsorb the agent. It's questionable if you should use cold or warm compresses, and only in extreme cases where you're concerned about compartment syndrome would you need to have urgent surgical consultation. Allergic reactions are in general pretty uncommon, less than 1% for sure. And then severe life-threatening reactions are possible, but also very rare. We're talking no more than 0.01%. We'll show a little bit of data sort of confirming that. But the ACR has some nice reference cards where if you have various adverse events related to contrast agents, this is what you do. If you have contrast extravasation, hives or diffuse erythema, hypotension. So now we're getting into more of the anaphylactic type reactions, things to do. And so most of these are sort of, supportive management, and you might consider Benadryl. But then when you get into the realm of anaphylaxis, you're starting to reach for things like epinephrine or calling 911 or code blue. Looking at adverse events across a multi-center MR registry. So this is data from the European Society of Cardiovascular Radiology. Most institutions use only one agent, but some of them use 2, 3, even more agents at their institution. The number or the type, the actual agents themselves sort of vary, but Gatavist in this case was the most commonly used one. In this registry, 75% of the cardiac MRIs were done without stress, but actually 25% of them were done with stress. And in general, any acute events, any acute adverse events were very uncommon, less than 0.4%, and more commonly occurring in the patients who had stress tests. The vast majority of these were mild hypersensitivity reactions. Very, very uncommon to have any severe allergic reactions, less than 0.01%. We'll touch on nephrogenic systemic fibrosis briefly. So this is a condition that was first reported after gadolinium-based contrast agents gained widespread use. In fact, there were no cases of NSF prior to 1997. And this was, my understanding was, people were excited about the idea of a contrast agent that, unlike iodinated contrast for CTs, didn't have the stigma of potentially being nephrogenic or nephrotoxic. And so this was used fairly liberally in patients with renal dysfunction. And just by definition, when they first came on the market, those were the first generation agents. And it seems that and so this is what it looks like. It's sort of a diffuse thickening cutaneous lesions where it's a scleroderma-like syndrome following the use of contrast agents. And so the ACR has a manual where they classify the different contrast agents by group 1, 2, or 3, meaning which ones are most likely or least likely to be associated with NSF. And the ones that are associated with the greatest number are the oldest agents. Those are the group 1s where you would certainly want to avoid using those. The group 2 agents are agents with few, if any, unconfounded cases of NSF associated with them. And you'll see Multihance and Prohance and Gatavist, Dotarum are all included here. And then group 3 agents are just, there was limited data, but few, if any, unconfounded cases of NSF have been reported. What is the actual risk? Those patients with CKD stage 4 or 5 who were exposed to group 1, highest risk ones for NSF, have about a 1 to 7% chance of developing nephrogenic systemic fibrosis. but most of those patients who developed NSF were on dialysis at the time of exposure. There's only been one published case report of a patient with a GFR greater than 30 who had NSF. And so additional risk factors that you got to think about is things like acute kidney injury, where the creatinine and the calculated GFR might not actually be accurate. It might be closer to zero in the midst of an acute injury. Or if you're giving high doses and multiple doses of gadolinium-based contrast agents, especially in these patients with renal dysfunction. I will say that a lot of the, many of the studies, Dotarum, Magnavist, Prohance, Evavist, all of these have some data for using them in more advanced kidney dysfunction. So, CKD 3 or 4, end-stage renal disease on dialysis, 268 patients. Here we are with Prohance, the one that we use, 159 patients, CKD stages 3 to 5, CKD, up to 5. So all of these studies, with patient numbers in the 100s, there were no cases of NSF. And so there is some data to support using this with the newer agents, the group 2 agents, in advanced kidney dysfunction, and even in this case, end-stage renal disease on dialysis. There was a consensus statement published between the American College of Radiology and the National Kidney Foundation that addressed gadolinium-based contrast media in patients with kidney disease. And they had sort of 13 take-home points that I'd encourage you to read because I think they're very clinically relevant. I pulled out a few of them, which is that direct communication between the radiologist and the referring provider regarding risk of NSF is not necessary for group 2 agents, but it is suggested for group 3 agents in patients with GFR less than 30 or AKI. The risk of NSF is very low for a standard dose of group 2 agents, even in patients with GFR less than 30 or AKI. So it's not zero, but it's very low risk. They say dialysis should not be initiated or altered based on group 2 or 3 contrast administration. So sometimes there's that question of, okay, this patient's end-stage renal on dialysis. If we give a contrast agent, there is data to suggest that repeated dialysis sessions will clear the contrast agent more quickly, but it's never been definitive. The point in this consensus statement is that it's never been definitively associated with a lower risk of NSF, and so they don't actually advise doing that. Sometimes clinically we do it if we're particularly concerned about it, but based on this consensus statement, they don't necessarily recommend it. The on-label dosing of group 2 or group 3 contrast agents does not have a clinically important risk of nephrotoxicity, so it doesn't directly cause AKI, as has been implicated, maybe controversially, with the iodinated contrast agents. So that's the renal dysfunction and NSF issues. The other thing that comes up is the issues of brain deposits, brain deposition of gadolinium after using these agents. So this was a FDA safety announcement from 2015, where they announced that they were investigating the risk of brain deposits following the repeated use of gadolinium-based contrast agents for MRI. And they noted recent publications in the literature have reported that deposits of these gadolinium-based contrast agents remain in the brains of some patients who undergo 4 or more contrast MRI scans long after the last administration. So this is where some of that data came from, which is you looked at individuals who had multiple sclerosis or brain metastasis who were getting repeated MRIs to stage their disease, and in this case, the 12th enhanced MRI and the 20th enhanced MRI, and you saw that there was these images are actually acquired before giving the contrast in this particular exam, but these areas right here in the dentate nucleus are already bright, and so they're realizing that there's already accumulation of the prior contrast agents here. And it seems that the number of scans that you got had a relationship with how much that dentate nucleus enhanced. So a little bit concerning that there's some accumulation of it, accumulation of gadolinium in the brains. But this is, and then this is again, a number of gadolinium administrations and increases in dentate nucleus signal intensity. But what should hopefully be a little bit comforting is that it seems that this deposition is dependent on which chelation structure you're using with your contrast agent. So remember, the gadolinium isn't given by itself; it's given within a chelation structure, and that determines sort of the chemical version and the trade name that we're using. So there's linear versus macrocyclic chelation structures. And what they saw was that in the linear gadolinium-based contrast agents, there is this relationship between number of scans that they received and unenhanced signal intensity of the dentate nucleus. Whereas in the macrocyclic agents, there's actually, it doesn't matter if you got 15 scans, there was no increase there. So it looks like the linear ones are most at risk for depositing within the brain. The macrocyclic gadolinium-based contrast agents, again, Prohance, Dotarum, Gatavis, these are all macrocyclic ones. Multihance is a linear, but the macrocyclic ones seem to not deposit like that. And so, this is another study showing that a linear agent was associated with brain deposition, a macrocyclic agent was not. So the FDA updated its announcement to say that in 2017, we identified no evidence to date that gadolinium retention in the brain is harmful, and so restricting gadolinium-based contrast agents use is not warranted at this time. We will continue to assess the safety of gadolinium-based contrast agents and plan to have a public meeting on this in the future. And so in the future, then later in 2017, they required a new class warning for the gadolinium-based contrast agents, but then again reiterated it has not been directly linked to adverse health.
Right? But basically, is there anything else?
But it has not been directly linked to adverse health effects on patients with normal kidney function, and they decided that the benefit of using the contrast agents continues to outweigh any potential risks. They did note later that linear gadolinium-based contrast agents result in more retention and retention for a longer time than macrocyclic gadolinium-based contrast agents. They didn't necessarily restrict the use of linear gadolinium-based contrast agents, which is different from the European Medicines Agency, where they did restrict linear contrast agents in body scans. And so they said, macrocyclic retain, maintain, suspend. They restricted some of these to like multi-hance for use in liver scans. And what they noticed is that over time, the use of linear agents went from about 15% of exams down to 1% in 2018, 2019. So the European agencies have taken a more restrictive approach to linear agents after seeing this data. There is some data that there might be some deposition after macrocyclic agents. So this is a study in 100 healthy participants and women who were enrolled in high-risk screening center for hereditary breast cancer. So a number of them were exposed to multiple doses of macrocyclic gadolinium-based contrast agents, and then half of them were contrast naive. And they tried to look for the same association. You can see that there's not very strong associations here. Statistically, there was a very small, significant increase in the dentate nucleus of women who had received multiple doses of macrocyclic, but visually it was in no way apparent. And so certainly it seems much less dramatic than what's seen in the linear agents. So with that, I'll just kind of summarize. So gadolinium-based contrast agents, they do enhance the diagnostic and prognostic power of CMR in multiple clinical scenarios. You do need to know about nephrogenic systemic fibrosis, brain accumulation of gadolinium, and allergic reactions because those are a concern, but they have decreased significantly with patient selection, including of those with renal dysfunction and macrocyclic chelation structures. There are non-gadolinium-based contrast agents based with manganese and ferumoxytol that remain a potential area for future translation. And so some of the frequently asked questions that we get are, what do we need to use contrast for to accomplish with a CMR scan? We don't need it for cardiac structure and function. We do need it for delayed enhancement imaging. We don't need it for valve or flow interrogations. You can get, actually decent views of the vessels and measurements without it, but for a true proper angiography, you do need it. You do need it for vasodilator stress tests because that's what our perfusion assessment depends on, and you do need it for thrombus assessment because we need those post-contrast long TI sequences to really look for it well. Patient with a CKD at a baseline GFR of 40, is there a risk of further deterioration of renal function with administration of gadolinium-based contrast agent? The consensus statement says no, there is no established risk of direct nephrotoxicity. So with that, I'll go ahead and close, and would welcome any questions or comments. And Shannon, do you mind putting up the CME slide?
Thank you, Dr. Trankle. I always appreciate your explanations. If it's okay, I have a quick question. This is Aditi.
Yeah, of course.
So, as you noted, the group 2 agents, the macrocyclic agents, are less associated with nephrogenic systemic fibrosis, as well as other adverse events such as deposits in the brain. And I know that they're slowly phasing away from the linear agents. What is the consensus about using the contrast in patients who have a GFR less than, say, 20 as the cutoff? And if that's the case, what is the potential for using the ferumoxytol or iron-based agents in patients with CKD if we really need the cardiac scan?
Yeah, so it's a great question. I think just the first part is, the standard GFR cutoff is 30. Although if you really look, the vast majority of NSF cases occurred, again, with group 1 agents in patients with GFR less than 15. So maybe our GFR cutoff should be more like 15. But even still, can we scan patients with GFR less than 30, including on end-stage renal disease? The answer is yes. And we have done it. So what that ends up being is someone, ideally the person, the treating provider, should think through, how badly do I need this information from the test that I'm ordering, in our case, CMR, and is there any other way we can get this information? So for instance, I think CMR-based stress test is, probably the superior stress test, but there are other ways of doing ischemic evaluations. And so if someone's particularly concerned about NSF, and for whatever reason, then, they might not need to. Now, again, CMR is the superior stress test, and you've probably noticed we catch things all the time that we didn't even expect, like amyloid. So you still might want to use it in someone with a GFR less than 30, but it just requires that consideration, discussion with the patient that there is this theoretical risk. But that being said, because there are so many indications where CMR is really gives you the best information, or sometimes the only way to get the information. We have scanned several individuals with GFR less than 30 and as well as end-stage renal after sort of documenting that consideration, and knock on wood, no cases of NSF to our knowledge. And I think where other institutions I've heard have moved to make it a little bit easier or more streamlined to do that, to scan patients with low GFR and even end-stage renal. And it sounds like actually our institution is doing something similar, where it'll become, when you order the test, a epic click button, where if the patient has a low GFR, you have to sort of acknowledge that, click that you've considered the risk of NSF, and still feel that the benefits of receiving this information outweigh the potential risks, which is still quite low. Again, I don't want you to think that, the group 1 agents, 1 to 7% was the risk of NSF. The group 2 and 3 agents, likely much lower than that, if there's a risk at all. And then I think the second part of your question was, should we instead be using something like faramoxetol? I think there is a higher risk of allergic type reactions with things like faramoxetol. The infusion is also different. It's got a very long half-life, and so I think what you have to do, so it looks at different things too. So it's not going to just accumulate and scar the way we expect gadolinium to behave, right? And so if it's taken up by macrophages, so you could use it as an angiography, it seems like pretty easily. But if you're looking for tissue characterization within the myocardium, it shows you something much different, which is inflammatory activation, macrophage activity. And so it just gives you an entirely different study. I think it'll be interesting to see how that evolves, if that becomes important to us in cases like myocarditis or maybe transplant rejection or something like that. But it is a very different contrast agent, and it shows you very different things. So it's not just an easy substitute. And the infusion protocol, I actually want to get someone here to talk about how they use it, just on a little bit of a logistical manner, because I think a lot of the protocols, you give the infusion. Again, it's not a push, it's an infusion. And then you wait a long time before you actually do the study, if I recall looking at the papers, maybe even the next day. So I'll try to see if we can, I saw someone wrote a nice review article on these contrast agents. It'd be nice to get them to come and speak to us.
Thank you so much. That's an awesome explanation, Dr. Trankle. And then if it's okay, I have David here who also has a question.
Yeah, of course.
Hey, Dr. Trankle, I was wondering if you could speak on the quote unquote latest and greatest contrast agents, Vueway and Illucerum, that hit the market this year.
Oh yeah, I can't comment on them yet. I tried to look. So I tried to look to see if any new agents had been specifically approved for cardiac, and I didn't find any as far as I know. And someone speak up if you know otherwise. Gadavis was the only one, but so yeah, I don't know. I'd have to look those two up and see if they're, hopefully they're macrocyclic and extracellular space ones that could be useful to us. But yeah, sorry, I can't speak to them directly.
Hey, Cory, it's Etsoi. Wonderful talk. A question for you with regards to the class 2 agents and NSF. I know there's these kind of low volume studies suggesting that NSF is not that prevalent. You weren't looking at a high degree to begin with. But is there some type of correlation between the fact that we were probably using a whole lot less gadolinium when these hit the market? I have this conversation back and forth with nephrologists that say there's no particular strong data and they track it, but I think we've been avoiding it for a long time. So if you don't give it, you're not going to see it. That's a big question that comes up regularly. And then second, for many of our cardiac studies, we're giving 1.5 times the gadolinium dose than many other studies. Do you take that into account?
Yeah, no, great to see you in the call, Ed. And I think your point's very well taken, which is that once it was recognized, the association with renal dysfunction, they very aggressively restricted the use of it in GFR less than 30, and certainly end-stage renal disease. So the cases of NSF all but vanished for a long period of time. And so that is kind of the catch-22 of trying to determine the safety of giving these group 2 agents. I think, I have to say, and maybe we should just do the work ourselves and sort of mine our own data and see how many patients we've exposed to gadolinium-based contrast agents in a retrospective manner. Because my hunch is that it's a lot of patients, and show that we haven't experienced any cases of NSF. Certainly that would have been a reportable condition. Will always be sort of, unless you do it prospectively, I guess it will always be sort of, you'll wonder if you caught all the cases if you just have a retrospective study design. But Yeah, I think your point is well taken, which is that we don't see it anymore, but we're also very cautious with giving it. I think anecdotally, our institution has noticed a little bit more of a liberal use, and I think some of it's come from our nephrology team that's really been pretty convinced by what literature is out there and their own experience at our institution, that they've sort of allowed it. They're sort of seen as the gatekeepers sometimes of the gadolinium contrast agents and their CKD population, even though that shouldn't necessarily be their role. And they've seen that they haven't experienced any cases of it, and so they're pretty quick to sort of give permission if it's a very reasonable indication. I think again, it just sort of, we love to brag about everything we can do in CMR, but I think it just requires some consideration of, do we really need this study? If we're working up amyloid, could we go down the PYP and light chain route, or whatever it is? Viability, is there another option if you want that? So as long as there's just a really good indication and everybody, including the patient, understands, I think we've felt pretty comfortable still giving it. But I hope that there's more data to come in this space soon, because if we can stop worrying about this, or at least have some more precise numbers of the true incidence of NSF and these group 2 agents, then that'll be something I think that would be really useful for our labs.
Yeah, I think once we start opening the floodgates for, I think in my institution we don't have PEP availability yet, so viability studies, and as you know, thallium is really not available anymore, so viability studies are really only cardiac MRI for now. They will do stress echo occasionally, but that's not nearly as good. So I get asked this a fair amount, and the nephrologist will say, yeah, it's okay. Yeah, it's okay. Yeah, it's okay. And I'm really reticent to open up the floodgates of viability studies with low GFRs. I would love to hear what you feel in the future, maybe in a year or 2 or 3.
Yeah, hopefully we have some stronger data to lean on, and can confirm what we and the nephrology team seem to be noticing, which is that it's probably safe, but more data to come. All right, well, we're over time a bit, so we'll go ahead and close the session. Thanks everyone for attending, and we'll see everybody back next week.